זה נותן קצת פרספקטיבה של הדברים, שום דבר לא התחדש, רק מינול הפרזובר השתנה, כמו שאבי אמר. Now, I'll turn, with your permission, אני הולך לדבר על בן אדם שמבין עברית, but it would be much easier in English. It's an honor and a great pleasure for me to invite Professor STEG to the podium to give the concluding remarks regarding this, I might say, I think, wonderful and very successful day. Professor STEG is well-known cardiologist, one of the leaders in Europe and worldwide, and actually doesn't need any introduction, not in Israel and actually not everywhere else in the world, but to the very few people that might not know Gabriel, I will say a few words. Gabriel works as interventional cardiologist, and he is the head of the CCU in, I hope I'm pronouncing it right, I was working on it with Dr. Agranat, Hôpital, Bichat. It's behind the Bichat, okay. Where is Owen? Owen is not here. Anyway, he's the head of the CCU in interventional cardiologist. He's leading research-wise. He has one wonderful group, very productive, of research in the field of atrial thrombosis. He's the head of the group. Besides this, he's well known for his clinical studies in the field of ACS. I wouldn't count the entire studies or the non-studies, but I think many of them were mentioned today, among which is the Euromax, Plato, Champion, Infusamide, Fastamine. Excuse me for forgetting, I believe, many of them. He's a professor in Paris University, and he's carrying a very prestigious job in the European Society of Cardiology. He is chairing the working group of thrombosis. He has, listen to this, not less than 300 published papers, and regarding the axis, he is the co-chairing of the GRACE Committee for Publication, so he might know something about registries. But we mentioned the ST elevation MI. He's the father and the mother of the ST elevation, the European guidelines of ST elevation MI guidelines, so we have to be very careful when we are mentioning the ST elevation MI. But really, and I'm serious about this, the most important thing is a very dear and supporting, and I can tell you it from the work in the European Society of Cardiology. I see Doron is saying yes. He's very supportive and very fond of the Israeli cardiology, and I can tell you that a month ago we met in Rome in another convention, and I was hesitating and asking, would you be able to give the conclusion remark to the axis, and it took exactly 15 seconds. Yes, I know the axis very well. Don't tell me about the axis. It's a very important thing. Yes, I do. I will be there. So, Gabriel, thank you very much.
Thank you. It's a true honor to be here. I'm really delighted to be here with you this morning. I will not give a presentation. I think you've had enough slides for this morning. I thought that what I could do is spend a few minutes discussing some of the impressions I had from the data that was displayed this morning. The first comment I want to make is I was impressed with the excellent outcomes that are achieved. I think overall there is no question that the very low mortality, the low morbidity, the very low bleeding rates that are achieved overall in the AXIS registry are a testimony to the remarkable care that is given to Israeli patients by Israeli cardiologists. I think you should be congratulated on achieving this. There's a message here for all of us. If the outcomes of patients who make it to the hospital alive are so good, maybe our next frontier is not in the hospital. Maybe our next frontier is before the hospital, for patients who die before they get access to the hospital system. And indeed, there's been, I've tried to follow some of the discussion on the hospital delays from first medical contact to reperfusion, and I think we all agree that it's going to be difficult to bring those delays down, And we're not even sure that bringing those delays down improves outcomes, as we've seen evidence recently from our US colleagues. We may have maxed out on the first medical contact to reperfusion delays and their impact on outcomes. However, we do know that we need to bring the earlier delays lower, and certainly we need to care for patients before they get access to the hospital system. Bringing the symptom onset to first medical contact delay is difficult. I think Doron made the remark. It is difficult, the effect it's costly, and the effect is short-lived, and the effect is minimal. What we can do, however, is we can try to build the systems that provide care for patients who will have cardiac arrest before the hospital. And I was very impressed in seeing the event rates that occur during transportation for patients being transferred via the mobile intensive care units to the hospital. And then the next column was patients being transferred by the ambulance. And of course the column was blank because no procedure could occur in these patients. But it doesn't mean that no event occurred. Most likely, at least as many events, if not more events, occurred in these patients. They just didn't make it alive to the hospital because they couldn't be resuscitated from cardiac arrest in the pre-hospital setting. So I think clearly, to me, this is the next frontier. There's also one aspect where we can improve outcomes, and I think that is the secondary prevention patients. We recognize it is difficult to educate the lay population about the need to call if they have chest pain and who to call and so on, and we know that this is expensive and not very effective. However, there are patients whom we are seeing and caring for who have had an event and who are at risk of having a subsequent event. And we need to educate those patients about what to do in case of recurrent symptoms, who to call. We need to give them a copy of their EKG as a reference EKG, should a new EKG be needed. I think that these are simple measures that make common sense and may impact outcomes. Finally, if I think of the avoidable deaths that remain to be taken care of, I think that really the out-of-hospital cardiac arrest and sudden cardiac deaths is the new challenge for us, where we can make a difference in improving outcomes. And I understand that this working group is working on a pre-hospital registry of sudden cardiac deaths. I think this is clearly the way of the future. This is where we can make a difference for more patients to come. There were many interesting debates about aborted STEMIs, about treatment for non-estivation ACS. Aborted STEMIs, I think we all recognize are an interesting group with a very good outcome anyway. It's going to be hard to do randomized trials in this group and show improved outcomes because their outcomes are so good in the first place. There were interesting debates about antithrombotic therapy. Some of the debates are somewhat Talmudic, whether you like clopidogrel, ticagrelor, prasugrel. To some extent, I think reminds me of other debates in other fields where we can debate a lot of pilpul about the subtleties of antithrombotic therapy. I do, however, think that the newer antithrombotic therapies are improvement. I think the reasons the guidelines gave grade 1 recommendations to the newer P2Y12 receptor blockers is that they improve outcomes, and for some of them they even improve cardiovascular mortality, and we should try to really implement the therapies. I was surprised to see little use of fondaparinux, again, that was pointed out for non-estivation ACS patients, but I think that reflects the importance of the industry sponsoring and promotion of drugs. If industry is not promoting drugs, they are not being used. And I think it's also what the French call a stone in our garden, that we need sometimes to implement evidence-based therapies even if they're not being promoted by industry, if the evidence is strong. I will conclude with 3 general remarks. The first one is the importance of comorbidities. Now that we are being so effective at treating ACS patients, I, like probably many of you, I feel when I'm doing the rounds in the morning in my CCU, that the STEMI patient is the easy patient. STEMI patient comes in, PCI, out of the door in 2 to 3 days. The more complex patients are the heart failure patients, the endocarditis patients, the valvular disease patients, the arrhythmia patients. They have all sorts of comorbidities, COPD, renal failure, diabetes, infection, dementia, and this is becoming more and more of a problem. And our CCU is turning into a general intensive care unit most of the time, and we're spending more time and more effort in dealing with the non-cardiac conditions than we are with the cardiac conditions. And I think we should reflect that in our training and our organization, because indeed the cardiac diseases are now the easy part of our job. The second general remark is the variability in the care. I think it was pointed out, in particular for the use of antiplatelet agents, that there's tremendous variability in care. And I think we have to recognize that the care of ACS patients is complex. It's complicated because we have so many choices. We have to make decisions in the emergency, and there are many stakeholders, from the ambulance physician, the ER physicians, the CCU physicians, the interventionist, the surgeon, the family physician, the treating cardiologist. Many people interact, and I think the way forward with this complexity to avoid disorder and errors is to have written protocols and adhere to those protocols. And although you may have your own preference on which anti-P2Y12 agent you would like to use for this and that patient, maybe having a standardized written protocol that is used consistently is better than having a piecemeal decision-making process at 3 a.m. in the morning by junior physicians. So I think that's a general recommendation that probably needs some thinking. And my final remark is really to congratulate the organizers and the people who have collected this data. I think that collecting data in comprehensive registries, as you are doing, is the key to improving the outcomes for our patients. It's truly a labor of love, and I think you should be congratulated for performing ACCESS, and I hope you continue to do ACCESS for many years to come.
אני רוצה להודות ליושבי ראש ולפאנליסטים שעשו עבודה פנטסטית ועשו את היום הזה מדהים, ושבת שלום לכולם ותודה רבה.